Good evening, everybody. We're going to go, in the interest of time, we'll go ahead and get started. My name is John Andrews. I'm the Associate Dean for Graduate Medical Education, and I'm pleased that all of you came tonight. I hope you find the workshop that we're offering tonight valuable. This is one in a series of transition to practice workshops that we've been preparing in collaboration with the Resident Leadership Council and also working with the Minnesota Medical Association, and it really is designed to meet a need that has come from the input of a lot of people in our graduate medical education programs who have asked for some information about some of the more practical aspects of work and life in medicine beyond their training. And so this is the second in a series of workshops that we're offering. As I said, I hope you find it valuable, and down the road we welcome your suggestions and your ideas about future workshops that we might offer. Tonight's workshop is really designed to cover a couple of areas, and to cover those areas we've got 2 doctors and 2 lawyers, and we'll keep them separated. The first part of the workshop is going to address practice options, and to that end Valaas-Turner, who's a graduate of our Med-Peds program, and Flynn are both here. Ann currently works at the Allina Richfield Clinic, and Tom works for the Minnesota Oncology group, and they're going to talk to you a little bit about their experience working in different practice models. And as they have a chance to address you, we want to leave plenty of time for questions and discussion, so we hope you'll find this an interactive session. And then in the second half, we're going to talk about employment and contract negotiations, and for that purpose, we have Teresa, who's an attorney with the Minnesota Medical Association. We also have Topp, who works as a healthcare attorney with Dorsey and Whitney, and they'll share some guidance and some information for you about that. So, without further ado, I'd like to invite Ann and Tom up to the podium, or perhaps in sequence. And Ann, do you want to use a lapel mic, or do you want to hold one in your hands? All right. So again, this is Ann Valaas-Turner. She's a graduate of one of our residency programs and currently working at the Allina Richfield Clinic. Thanks for being here.
All right. So my name is Ann Valaas-Turner. I do internal medicine, pediatrics, outpatient primary care. And I work for the man. Corporate medicine. When I was doing my job search, trying to figure out what I wanted to do, there really wasn't a huge question in my mind, really, in the world of primary care for whether I wanted to work in a large multi-specialty group or whether I wanted to work with a smaller independent group. In the Twin Cities market, you are primarily going to be looking at jobs with the larger groups if you are in a primary care specialty. But I'll cover kind of two topics today. The first is just what do I like about working in corporate medicine. And then the second is just a little bit about how do you get started with finding a job, and what are some things that you might want to look at as you are evaluating your options. So things that I like about working in corporate medicine, I love it that everything is taken care of for me except for doing the actual medicine. I don't worry at all about the office staff, about whether the lights are paid. All I do is show up every morning. Someone else hires my medical assistant for me and makes sure my medical assistant is paid and makes sure she's at work on time, and everything else, everything's taken care of. I like the fact that I work in a large organization, that I have specialists that are available to me, that we can coordinate care in an efficient manner, and that we really can get our patients better care because we can coordinate the care. I like all the resources that I have at my fingertips. I like that I can call up radiology, I can call up anesthesia, that I just can get my patients the care that I think that they need in a quick and efficient manner. Some things that are sometimes difficult about working in corporate medicine, I do get told what to do a lot. And you do have to have a certain amount of a tolerance for understanding that there will be trends in medicine that you can't always follow, and sometimes you just have to smile and nod your head and say, all right, fine. This is what we're doing right now, and as long as it's not seriously harming my patient, that's what we're doing. So an example would be often diabetes quality guidelines. The research on diabetes care trickles down, but the Minnesota community measures people, the people who measure whether or not you're taking adequate care of your diabetics, that often lags by a year or two. So you are fulfilling quality things that the research then is saying actually it really doesn't matter anymore. So that would be a downside. And there are decisions that trickle down from on high sometimes that it's not always clear from the position in the trenches of where those decisions came from. But I have no regrets whatsoever about having gone to work for Allina. I also like that I have the flexibility. If I want, I can transfer between locations. I also like the ability to change my working hours. So when I started, I was 80% time. I had 2 babies, I went to 65% time. I took a 4-month maternity leave each time I was on maternity leave. And my partners took care of my patients, and the office staff still got paid. And it was fairly seamless for me to be able to be gone, take care of my family, and come back. I like being covered by FMLA. I've also, working in a large organization, I did take a leave on behalf of my husband, and it was awfully nice to be able to do that and know that I was legally protected. It is less of an issue now for health insurance, but because you are not allowed to be denied health insurance for pre-existing conditions. But at the time that I was looking for my job, working for a private practice was out of the question because my husband is commercially uninsurable, and we just absolutely had to be on a group plan. It is something to think about, though, if you have something that would make it hard for you to get either disability insurance or life insurance working in a private practice group. You may want to look into your options before you do that. I have a colleague who was going to sign with a private group and realized that because of her history of melanoma, she was uninsurable. And so she went to work for Health Partners instead. So again, working in a large organization, you have a lot of the protections that come with working in a large organization, and the downside to that is you sacrifice some self-determination and some flexibility. As far as the search for a job goes, this is about the time that you should be starting to think about evaluating your options. This is a good time to think about where you might want to work. Get in contact with the recruiters for the various organizations if you want to stay in the Twin Cities or if you want to go somewhere else. A secret of job recruiting is that often there are positions available that are not posted. So my clinic is almost always hiring if the right person contacts us. It's rare that we have a position posted. So if you know somewhere that you might want to work, it can pay to contact them directly and say, hey, I'm really interested in your site. Can we talk? Another thing that some people do is if you know where you want to work and there isn't a position, sometimes joining the float pool of the organization that you want to go to and having that conversation with the site that you want to work at, that if something opens up, you would like to be able to go there. So one of my colleagues was in the Allina float pool for 6 months because he really wanted to work at our clinic and we didn't have anything at that point in time, and he just waited until something opened up. When you are interviewing, and this is an entire other discussion, but it's really helpful to be able to cluster interviews together so that you can really evaluate clinics head-to-head before you have to make a decision, or positions head-to-head before you have to make a decision on any one particular position. When I was looking at sites, the thing that was the absolute most important to me was who my coworkers were going to be. And that pretty much drove things for me, in addition to I was looking for a site that would have flexibility for part-time work and family. I was very much looking for somewhere that had a collegial feel, that it seemed like everyone at the practice was working together, both physicians and staff. When you are starting, they will have guarantees of this much, and that you will have if you're on a RVU basis, they'll tell you how many RVUs you're expected to make in a year, and as long as it's consistent with kind of the average in the community that you're going to, I really don't think that a small amount of money should drive your decision one way or another. Because in the end, what's going to make you happy is the people that you work with and not the money. All right, so other things to think about when you are evaluating a site and maybe you're about ready to sign, is how much time they're going to give you to get on your feet with your practice. It takes a lot to transition from residency to being full-time staff, and the best sites are going to give you a little bit of a bridge time where you aren't expected to see a full panel starting on day one. So they'll give you some time to maybe see, fill your schedule halfway and then work up to filling your schedule 3/4 of the way before you are working with a full schedule. Because whatever site you're at, they should be invested in making you be the best physician that you can be, and not in just pulling in the numbers and generating the RVUs. Another thing to look at when you are looking at a site is continuing medical education and how that works. Do you get a pool of money to do your continuing medical education? Is there continuing medical education that is offered by your organization? Is there any sort of within your group, does your group do anything to try and stay current and discuss the medical issues that affect your patients? Another thing to think about when you are transitioning into practice is it takes a very, very long time from when you sign with the group to when you are ready to start. Typically, the credentialing process takes 5 months or so, which is part of the reason why now is the time to be looking for a job if you are a third-year resident. Because even if they get started, if you sign in January, you're not going to be ready to see patients for quite some time. All right, well, I will hand over the mic.
Thanks, Ann, and we'll have Ann hang out, and maybe after Tom makes some remarks, there'll be some further questions and discussion you'd like to have. As I said earlier, pleased to welcome Tom Flynn. Tom works in Minnesota Oncology.
Can you hear me okay? So now that we have the technology and manual dexterity issues solved here. Okay. So Ann has given you lots of great advice about how to look at positions, and obviously has given you her perspective on working for a large health system, which is, obviously I think a trend both nationally and locally. More and more people seem to be going into those types of positions, and those positions have a lot to offer. My task with you this evening is to talk about independent practice and how you might think about that as another option for where to head in your career. I had the opportunity to be a part of a task force that the Minnesota Medical Association put together to look at independent practice and some of the issues that we're facing people in independent practice and what the Medical Association might be able to do to help look at some of those things. And one of the things that we did first off was try to define what is independent practice. What does that mean? Well, we came up with three criteria. It's physician ownership, physician governance, and the physician owners have a business and financial risk. In Minnesota, there are somewhere between 12,500 and 15,500 practicing physicians. Of those, approximately 4,000 or so, as best can be determined, are in a independent practice, so about 30%. So why are more physicians moving to a employment status working within hospitals or hospital systems? My personal view is that there are a number of reasons for that. One is the Affordable Care Act and the requirements that come with all of that. That has put a number of things in place that are at times difficult, especially for a small independent practice to deal with. There are, even without the Affordable Care Act, I think, clearly going to be changes in how we are paid for the care that we provide. And by that I mean that there will be a shift from what has been classically the case for decades of or probably centuries, of a fee-for-service structure whereby you get paid for the services that you provide, be it by a third-party payer or the government or patient's own research. So that structure is expected, I think, by all to gradually disappear. It's not going to change overnight, but gradually in the coming years it's going to shift to a situation where we are paid in other ways. We are paid for the value of the services that we provide. And by that I mean looking at the ability to provide quality care at lesser cost and still maintain patient experience at a high level that they expect to receive. So there will likely be models whereby you're paid for an episode of care, where you are paid for several months of care for a particular illness. Or in oncology, which I practice, we might get a payment for 6 months worth of adjuvant treatment after surgery for breast cancer. And ultimately, the trend may continue to head toward capitation, which means that you are paid essentially so many dollars per month per population that you serve, and your job is to then be able to provide that care for that amount of money. There are a lot of administrative costs that are out there. Electronic health records are all but mandatory nowadays. The government is providing incentives for practices to install electronic health records, but there's costs associated with that far exceeds what the government programs are going to provide. And there's a lot of work involved in implementing those, and also then doing what is called meaningful use, demonstrating that you actually use the record and do things that are considered meaningful in the Medicare and Medicaid eyes of utilizing that record to its important extent. Information technology is expanding, obviously, and data is critically important for a whole variety of reasons, not the least of which is to be able to document the care that you provide and submit the charges for that care appropriately. ICD-10, the new diagnosis codes that's coming into place October 2015, much more complex than what we use now, whereby you have to be highly specific around the diagnosis code. And, in oncology, which I know best, for example, which quadrant of the breast the cancer arose in, which most oncologists, and probably all oncologists would tell you, doesn't make one whit of difference as to how I treat that patient. But the more specificity that's required, the more effort that's involved in trying to do all that documentation. Physician credentialing, Ann said it's a long process, and so that can be something that's costly for independent practice to be able to accomplish. And all of this is happening in the face of declining reimbursement, sequestration, cut Medicare reimbursement, and other payers are constantly exerting pressure to try to reduce reimbursement for care in order to control costs. And so there's, I think, a perception, which isn't entirely untrue, that hospitals and large systems are better able to address some of these things and pay for those requirements. I think the other factors are that independent practices often perceive that they are in competition with hospitals and large systems, particularly if they're vertically integrated and have both primary care and specialty care and a variety of services such that they can control where patients receive their care. And the other thing about large systems is that they are likely to have much better access to capital to make investments in a practice or to buy new equipment. And in a typical small independent practice, physicians would often have to assign personal guarantees for loans to be able to put those things in place. But I think the other point in all this is that the hospitals and the health systems are also going to have to deal with these new reimbursement models, and in many ways I think you could argue that they have significantly more risk in that where there are opportunities for cost reduction, at least initially, may well focus on reducing hospital admissions and also things that are in place already to impact hospitals for readmissions within a certain period of time and to not compensate for care that occurs as a result of complications that occurred in the hospital setting. So, as we said, part of the definition of independent practice is physician governance and physician ownership. And with that then comes, on the very positive side for me, is the ability to control how your practice does things, to have a say in where you refer your patients for specialty care, where they get their laboratory testing done, where they have their imaging done, places that you are comfortable working with and feel provide best care for your patients. There are entrepreneurial opportunities potentially in practices to provide ancillary services that are appropriate to the population that they care for, and an opportunity there to help generate revenue to offset some of these costs. You have the opportunity through your physician governance to determine compensation models and essentially how you pay each other for the work that you do. And the administrative and the operational staff take direction from the physician leadership. I think that while you certainly can have long-term relationships with patients in a system practice, that is something that I think also applies to independent practice, and in my personal opinion, perhaps to a greater extent, that one develops longer relationships and more deeper relationships with the patients that they care for, with the referring physicians that they work with, and other professional colleagues. The flip side, of course, again, is there is financial risks. If you are an owner, partner in an independent practice, you are the last to get paid. There is no guaranteed salary, except that you would likely receive some type of guarantee the first couple of years you were in an independent practice. They can't realistically hire anybody if they aren't able to provide you with some guaranteed base income for at least the first couple of years while you build your practice. And there is certainly a need for at least some physicians in practice to be involved in the business aspects and to oversee the management team of the practice. And you need physician governance to define your clinical protocols and quality measures and create those on your own rather than having them be sent to you from a more central administration. So I think that one word that I think sort of summarizes the differences between those two kinds of practice is autonomy. I think that in independent practice you have more autonomy, you have greater ability to determine your own destiny, and greater opportunity to be involved in developing the practice in a way that you think is best to provide the care that you want to give to the patients that you serve. I sort of come from three worlds, and I've been around in practice a lot longer than Ann perhaps, but my first 7 years I was at St. Paul Ramsey Medical Center, which is now called Regents Hospital. Back when I was there in the early 80s, it was a city-county hospital. It was one of the major teaching hospitals for the university. And I worked there and was on full-time faculty at the university for those years, and had certainly a satisfying practice there. It was something though where I had little self-determination in terms of how I was going to take my, what direction I would take my practice, what I would be paid, and had absolutely no say in the staff that I worked with. I left there after 7 years and joined a private group of 7 doctors. I was doctor number 7, so a very small group. And at that time, all the physicians were on the board of directors of the practice, and we essentially managed the practice that way. So it was a management structure. We hired and fired people who made those decisions, and had to make decisions around employee pay and benefits and those sorts of issues. Our practice has now grown to nearly 60 physicians, so it's a very different sort of practice than it was when I first joined the group. And while we remain an independent group, we certainly have the size that helps us in a number of ways, helps us to be able to afford many of these new things like the electronic health records and IT equipment and services that we need to be able to utilize. It gives us a bit more influence with payers when you're negotiating contracts around what you're going to get paid for the care that you provide. So large groups have in some ways similar capabilities to hospital systems, and yet still maintain the independence and the physician direction and physician governance. So I've often said that I have been very, very pleased with my decision to join an independent group. I've been very fulfilled in my career. I've worked very hard, and certainly came home tired many days after a long day of being in clinic and then going back to the hospital to see some patients who needed attention or whose families needed opportunity to discuss the care of their loved one. So certainly I've been extremely pleased and been doing it for 27 years, so I haven't changed my mind. So just a few little points of advice to close. My advice to you is to try to know yourself. Try to understand what you want out of your career and what gives you satisfaction. Do you want to be an owner, or do you want to be more of an employed physician? I think it is critical to understand the culture, and I think Ann mentioned this as well, understand the culture of the practice or the hospital system, whichever you're pursuing, and also understand, I think critically, how physician input is valued, be it in one of those systems or the other. For an independent practice, I think, as I tried to point out a little bit, there is a difference certainly between practices that have 1 to 10 physicians, say, and those that have 50 or more, in terms of what their abilities are to do things, and perhaps what their stability is around income, as well as the day-to-day issues around call coverage and ability to be away. I think that in the past, small independent practices would have the reputation that basically people worked 24/7, 365. Once you get to a reasonable size, that's certainly not the case, and it's been the case for me for many, many years that when I'm off, I'm off. I'm not expected to be available after 5 p.m. I'm not expected to be available on the weekends unless I'm the one on call. So I think the other important questions to ask are also, how is the practice or the hospital system that you're looking at for a position, how are they going to address the challenges of the changing reimbursement models? What is their thought process around how that's going to happen? Because I think that's a very important issue over the next 5 to 10 years. And I would just close by saying, please consider independent practice as certainly a very viable option.
Could you both please comment on liability or errors and omissions insurance and how you would, because I'd like to think someday I would have assets to protect, how you'd recommend looking into purchasing it, maybe from an independent standpoint, or how you can cover yourself so that you don't have any personal loss.
Allina pays for my malpractice insurance. And when I go volunteer somewhere, if I ask them, they will also, if they approve it, they will cover it. So, like, I was just volunteering for a week at a YMCA camp, and they covered malpractice insurance for that.
Thanks. I think, it's true in independent practice as well, they're likely going to be doing some type of group policy for malpractice. In terms of personal liability, I guess honestly I defer to our attorney colleagues, and I don't know if you're planning to address that.
I will. I'll
Okay.
address it. Good question.
It's a good question.
Yep.
So for an independent practice, there's a critical mass of physicians that must exist in order to succeed. Is there any way to estimate who would be best prepared for the changes in healthcare moving forward as we're applying through the system?
Well, I think I honestly have to say larger groups certainly are going to be better able to address those issues. Because if you're a very small group, if there's some risk product that you're involved in, some sort of patient care, third-party payer contract that has some risk involved in it. In other words, if you don't meet certain levels, or if you're, say, getting paid for a bundle of services or that sort of care, and you somehow exceed those costs significantly, obviously the larger number of people that you can spread that loss across, the less significant it is for the individual. So I think, and again, of course, I know oncology the best of anything. Certainly in oncology, medical oncology, small groups of 3 or 4 people are disappearing, and for all of those reasons that we talked about. But those like ours, which are larger, certainly can survive and thrive in any environment.
Thank you both for those talks. You're right, this is very fun to talk with me. I hope I can enunciate this question concisely. But as you start to ask maybe a large multi-specialty or a large group, how are they preparing to confront the changes of healthcare reimbursement? How do you begin to understand their answer? Like, where do you learn what that means and whether or not their answer reflects preparedness or gobbledygook or and the same from a financial standpoint, what are some questions as an interviewee that you can ask to ascertain the financial viability of your potential future investment that you're kind of marrying into?
Right, very good questions. I think, first of all, as far as the addressing of reimbursement changes, the first question is, do they recognize that in fact this is happening, and are they thinking about how to prepare for it? I think that we don't know exactly how this is all going to happen or at what pace it's going to happen. So it's hard to say that anybody should have a really detailed outline action plan of how they're going to do it. But be sure that they recognize that this is something that will have to be addressed, and ask about well, what are you doing? Do you have somebody within the practice or a group of people in the practice that are addressing these issues, that are working on these, that are thinking about these things? I think that's initial things to talk about. In terms of financial viability, you can ask, certainly you should be able to ask very specific questions about, is the financial performance of the practice stable over the last 5 years? What do you see happening going into the future? Do you see any reason why that's likely to change significantly?
And then it comes down to a trust. Like, you look them in the eye and you decide whether or not you believe them or not if you don't know anybody in the community. So ultimately, it kind of comes down to that.
Right, and certainly if you're interviewing any position, you're likely to be talking with multiple people, and so you can ask the same questions of more than one person.
So as somebody who knows almost nothing about independent practice models, when you're signing on, and are you paid in a salary up front, and is there some sort of guarantee for partial ownership at some point in the future, and how is that explicitly negotiated, and this is that discussed up front, or is that discussed later, and I don't know if you have comments about that.
No, excellent questions as well. I think, no, it's something that you definitely would talk about up front, and your employment agreement initially should spell all of that out, and you'll hear more about that in a little bit. But typically you have a guaranteed salary for 2 years. It varies a little bit from practice to practice, I'm sure, but typically 2 years. You have a base salary, that's contractually specified, and then typically a production bonus opportunity that would be on top of that, plus benefits. And then the other component you asked about is becoming, shareholder, owner of the practice, and partner. The employment agreement should specify at what point would you become eligible for that. It won't guarantee you partnership, because obviously that's a mutual decision that has to be made between you and the members of the practice and determine whether things are a good fit. But certainly appropriate to ask for what the time frame of that is happening. What happens if you aren't offered partnership? What happens if you are offered partnership? And if there are any specific criteria that the practice would use around being eligible for that.
Tom, maybe a follow-on to the question you got over here. You've been working in independent practice for a long time.
Mhm.
How much anxiety have you experienced over the course of those 27 years as you've met economic challenges to your practice and changing models? Have there been times when you thought it was all going to go south, or has it been smooth sailing and stable all the way?
Well, somewhere in the middle.
Yeah.
I think that I fortunately never was in a position where I thought that things were going to go south. We have seen ups and downs, and certainly, in the last several years with all the changes that have occurred, physician incomes have declined somewhat. And that's true in a lot of situations across the country. But not to a point where it's, anything that's, concerned about being able to provide well for your family. But yeah, there are anxieties that occur, and I think in an independent practice, those things are things that you do have to be prepared to be willing to think about and to work on and to work with your partners on to solve.
And has any of that stress from a large health system trickled down to you? Have there been threats to your income or your job security? Has this health system you're working in faced challenges?
None. Our practice actually absorbed an internal medicine practice that unraveled. And we took on 3 of their physicians as they were looking for a new position very, very quickly. Because their practice unraveled and they were financially liable and they had staff to pay that they couldn't pay. And it was a very difficult situation for them.
How large of a group?
6. The question was, I think it started off as 6, and it started off with their PA went on medical leave, and that was the first step in everything unraveling.
I have another question. So, regardless of whatever practice I go into, I want to understand the health changes that are going on. So, from, you get it from the media, and maybe you follow religiously the political back and forth, and you know what that level is about, which is not true in my case, but you know there's lots of stuff going on. What sources would you suggest that I or somebody look at to educate yourself on interpreting that for your life, for your job, for what it means for you in general surgery when X law is passed, or with these new requirements? You can talk to your group, but how do they get that understanding? Is there a resource? Is there do you just go to meetings and listen to other people talking about it? Or?
Yeah, I guess I would be hard pressed to come up with one single thing. I could say, go read this and you'll understand what's happening. I think that, excuse me, one thing that just comes to mind off the top of my head is the American College of Physician Executives. They would have a website we could go to, and probably would have some materials there that you could look into and find to get a little better understanding. I think it isn't going to be something that happens overnight. It's not going to be all of a sudden we wake up on January 1st and it's a whole new world. It's going to be very iterative, which in some ways is good, and in other ways makes it more difficult to figure out how exactly to adjust.
One other thing about that, I was just talking to our colleagues from the MMA, and they have a policy expert who addresses things like the Affordable Care Act and the impact of insurance, some of those other issues locally. And we can invite them to come and address a group like this as well, and that might be a helpful source of education. Yes?
Something that I've heard frequently through my training and that has been reiterated tonight is that it's very important to get into a practice with colleagues that you can work well with and that you're going to enjoy wanting to work with. But how do you determine that? I mean, I don't think that's something you can really figure out just from sitting down and talking to 1 or 2 people in an interview. So what's the process, or what have you guys found effective?
And you talked about that being important. Do you have a comment about that?
Well, I'm an extrovert. So honestly, for me, any practice where the physicians had their very own office and they sat by themselves in a room when they weren't seeing patients scared me. You can get a really good sense for a practice. Usually when you're applying, there'll be some sort of a lunch, an opportunity for you to meet the people that you're gonna be working with. And if it's only one or two people who trickle in to meet you, that's not a good sign. You know, really, like, some people are gonna be busy, they're not gonna be able to make it, but you would want to expect to be able to meet at least 50% of the people that you would be meeting with, that you would be working with. Asking too, like, what do you guys do outside of work? Do you have parties outside of work? Do you like each other? You know, my daughter wears the clothes that one of my coworkers' daughters wore first, and one of my other coworkers' daughters wore before that. And that kind of a community was really important to me, and you can get at that very quickly. I interviewed somewhere else where everyone worked in their own little office, and one of the physicians told me, I like this job because at 5 o'clock I close the door and I go home. And, you know, that's nice, but I wanted somewhere where the people told me I like this job because I like the people I work with.
No, I agree.
Yes.
Comparatively, what kind of compensation are you looking at when you join a private practice versus a institution? I understand that with private practice, typically your first couple of years, you're not making as much, but then after you say you buy into the practice, what's the comparison of the difference in compensation?
I would guess it varies quite a bit from specialty to specialty in terms of how those two things compare. I know certainly in oncology that hospital systems are able to compensate people at levels very much the same as we are. So, you know, I think that it's going to vary quite a bit. Especially, it's hard to give a blanket answer.
Well, do you see an economic argument for one model over the other in terms of future income? Or is it likely that compensation is similar depending upon the nature of the practice?
I guess I would say in independent practice, there's the opportunity for a higher level of compensation. But not necessarily the guarantee that that's going to be the case. And I mean, certainly for many years, we were able to provide compensation that was superior to a lot of other employed positions in the area, or looking at what's called MGMA, Medical Group Management Association. They produce numbers around the physician compensation. And we have been consistently above those numbers, but relative to local hospital systems, actually very similar in recent years.
At least 3 times the average salary for the U.S. worker.
Yes.
If you're looking at job positions outside of the market in the Twin Cities or even Minnesota, if you don't have significant sort of professional connections in the market that you're looking, how would you recommend going about looking for jobs in those different areas? Would you just kind of Google and look for recruiters, or would you ask your program director if they know any names? I was just curious if you could make some comments about that.
Is this a geographic area that is brand new to you that you want to try out, or one where you already have ties?
Not necessarily, I mean, a little bit of both. I think that, you know, I don't know if everyone here is planning on staying in Minnesota, but other people I think might be moving for family or partners where they may not personally have professional ties, but their partner may have sort of personal ties, or if you do have some professional, but it's limited to a college, but not medical school, for example.
So it never, if you have ties in an area, it never hurts just to ask around. Where do you go to the doctor? Do you like your doctor? Do you like your health system? And you can get a pretty good feeling for a health system just by people saying, oh my gosh, you know, don't go to Kaiser. Or, oh my gosh, I love working for Virginia Mason in Seattle. And then start sending out feelers for places that you want to work. Working with, I should clarify, there are two kinds of recruiters. There are in-house recruiters for large health systems, and their job is to put people in spots that their health system is hiring for. And then there are the private recruiting firms who typically are going to either be hired by a practice that's so small that they don't have in-house recruiting, or practices that are having a hard time filling their spots. And the annoying recruiters, the ones who page you all the time, those are the outside recruiters. In general, those are the ones who are going to be selling you spots that other people don't want for some reason or another. And typically you're much better off doing your own research and finding your own opportunities.
But the recruiters within health systems tend to be a very good resource.
And within a health system, they can tell you a lot about, you say, I want to work at a practice with a large Somali population and 5 doctors, and it needs to be close to a biking trail. And they know their clinics, and they can steer you in the direction that you want to go.
Tom, do you get contacted by people from out of state who wish to come and work in oncology or might like to join your practice?
We do. We've been fortunate. We have not had difficulty recruiting people. We do get a number of people that contact us. Because we're a larger group, we're fairly well known in the community. So if somebody has ties to Minnesota, wants to come back to the Twin Cities, somebody here will usually then tell them, well, you should talk to this group as one of your options. We have used some national recruiting services at times, but primarily it's been really kind of word of mouth or people that have grown up here or somewhere around in Minnesota and want to come back to the area.
And if someone were to cold call your clinic looking for a job, whom should they speak to?
Well, in our group, as a private group, the president of our practice is sort of the person who's in charge of doing the recruiting. We have HR people that can help with all the details around the benefits and all that. Initial contact would be the group leader.
As a corollary to that, we are most interested in people who want to work for us. If people take the initiative to find us and contact us, that's huge.
Partial answer to your question, I was given a website by an in-house recruiter, but it's for national in-house recruiters, kind of a website, aspr.org. I haven't looked at it yet, but just to consider. My question was in regards to the process of interviewing and hiring, compared to what your experiences were in the corporate and private settings. Do you feel like with that there's pressure in terms of the private setting to make a decision in a different amount of time, or to consider it differently if you're looking at both fields? Since private groups are smaller, is there a sense that there's a desire for a high level of commitment even going into an interview?
No, I wouldn't say that that's the case. And again, I can only really speak from the perspective of my experience in one practice. But I don't think we've ever been in a position where we've tried to, put pressure on people to make a decision quickly. There have been maybe a couple instances where it was dragging on for months, and we said, well, we really need to get an answer as to what you're not doing here. But I don't think it's a situation where you'd expect there to be a lot of pressure up front to move quickly on your decision.
I'll tell you what, I think we're going to move on, but I want to thank both Knoedler to come forward. She's an attorney with the Minnesota Medical Association. She'll tell you a bit about her role there. And then Teresa, I think you'll introduce Claire. Is that right? Do you want to wear the lapel mic, or would you like to?
Actually, I really want to use one of those CB radios badly, but it was vetoed. So, my name is Teresa Knoedler. I'm in-house at the Minnesota Medical Association. We are a physician professional association, and we represent physicians in Minnesota. Sometimes there's a little bit of a misconception that we are the Minnesota branch of the American Medical Association, and that's not true. we're separate and distinct, and we can make our own choices, and we do. So we represent Minnesota physicians. And I have to note, I was thinking as I heard your questions of the two previous speakers, that in part you can find some of the answers you're looking for at the Minnesota Medical Association or at the State Medical Association if you're going outstate. There's an opportunity to connect, an opportunity to get data that may not be public, that may be just a matter of making a phone call or getting hooked up with the right person to get the information that is very hard to come by, and that maybe only you can get from another physician. And how do you contact another physician? You reach out to the professional organization. So keep that in mind as you're looking for resources and you're looking for kind of the real answers that are hard to come by. So we partner in these transition to practice programs because it's so important to start your practice out right. And we know that, and happy physicians don't start out from a bad place, they start out from a happy place, is what we found out. Maybe that's obvious, but if not, breaking news. So we want to make sure that you're able to get started out right, and having an attorney is quite often, let's just go off.
Yeah, battery's good.
Should I yell? Do I get to use a CB radio?
It's not your fault.
Okay, so we provide general legal resources, and there can be times when all you need is an answer to a question that is a general question, and we can help you with that, and I can help you with that. And a lot of times we are a point of first contact for a physician who has a legal problem or wonders if maybe she has a legal problem, or simply would like to know, should I be talking to a lawyer? And that's where I can come in and I can say, yes, you should. And quite often I do say that. Other times I'm able to direct you to the appropriate resources, and you can save that $400, $500, $600 an hour fee. Now, let me be clear, when you need to spend that money, you need to spend the money. I'm not saying that you don't need an attorney, but I am saying that there are times when I can help sort through that kind of triage process about, do I need to call in an expert, or can I rely on the resources that I found publicly? And you know, I can't serve as your attorney, but I can help you sort through those issues and provide general support. And then another important thing that I just want to point out is that we maintain, and I maintain, a running list of referrals. One of the most important things you can do when contacting an attorney to help you through any process, and specifically the employment contracting process, is to make sure that you're connecting with someone who specializes in this work. Just as in medicine, law is not a general practice anymore, if it ever was, but it certainly isn't now. And so having someone who has familiarity with not just contracting, but physician employment and or partnership contracting is really important. And the list that I maintain is not a buy-in list. No one's paying us money to be on the list. It's a list of people who have been vetted and really sort of in a trial by fire have done good work on behalf of Minnesota physicians, and the physicians report that back to me, and then I pass that name on to you. And so it's a great resource. Because at some point in time, you're going to have grappled with the questions that you were just discussing for the last 45 minutes, and you're going to have to enter into a contract, whether the partnership contract, an employment contract, or simply a handshake, like a lot of the situation occurs down in Rochester, where it's merely a handshake. Well, what does that mean? And that's when you need a good attorney. Now, I will let Claire come up and speak because I know you guys are going to have a ton of questions for her, but I just want to point out that Claire is one of many attorneys that we have who have done good work on behalf of Minnesota physicians and can really help you understand what the landscape is like here as well as elsewhere, because there's a lot of transferability. This is Claire Topp. She's an attorney at Dorsey and Whitney. She specializes in health law and also does a lot of nonprofit law and represents physicians in employment negotiation.
Hi, I'm the only one who brought a PowerPoint because you can't go anywhere without a PowerPoint. But let me give you some background while that's getting set up. So first off, I've been at Dorsey for about 22 years. I hate to admit that, but it's true. And while I was sitting here, I was thinking about all the specialties that are probably sitting in the room, and I just made a list of all the contracts I've seen over those 22 years. So I've done GI, neurology, ophthalmology, radiation therapy, emergency medicine, internal medicine, OBGYN, trauma, pediatrics, oncology, orthopedics, rheumatology, family practice, endocrinology, and neurology. There are a couple others too, but gives you a pretty good sense of it. I would say as a general matter, contracts, while it's nice to have the idea of some idea about the subspecialty, they're generally the same. I also represent physicians all over the country. I started doing my work for the American Academy of Ophthalmology, and then of course for all the ophthalmologists kind of across the country. My first presentation actually was called More Than Meets the Eye, and yes, it was intentional. And actually what I've done over the years is I've collected the worst, and I want to be very clear, the worst provisions I've ever seen, because I put them up, and normally, by the way, this is an hour and 15 minutes, so you're getting the short and sweet version of it. So one of my favorite things to do is to talk about these, and I love to lure you along, show you a provision that I just literally pulled out of a contract over the years, and have you tell me what you think it says, and then tell you exactly what it doesn't say. It's all the things we can all read, right? But it's all the things it doesn't say that you're missing that underlie it. Two other quick things before I kind of go through this, and this is a shortened version of it. But I wanted to sort of address the question of this transition or this choice that people are making between going and working for big healthcare systems or going into private practice. Just in the last 2 years, I actually represented 6 different groups in South Dakota, and they were radiology, ENT, OBGYN, emergency medicine, and there were a couple others of them that all sold their practice to the local hospital. So there is a big shift that's been common and is continuing to come, where the smaller practices, and I don't know whether I would say these practices were all in the 6 to 10 physician range, and hearing the internal medicine one unwinding, that's not a surprise to me. There's so much pressure with the cost of putting in electronic medical records and the resources that are necessary, that having an access to capital is really important. I also think there's some lifestyle choices that are going on too. We see it in law as well. But people don't want to work 24/7. They don't want to be on call all the time. And when you're in a smaller group, you definitely have a lot more call responsibilities as you're sharing it, and you have a lot more financial risk incentive. Now, I do want to answer the question of, are you likely to do better off financially in a private practice versus working for a system? Where I would say the big upside, and I would say starting out, it's different within the noise. There's just not a lot of difference. But as you work kind of longer, the upside comes in the access to reimbursement from ancillaries. And it's not the professional services and the delivery of professional services. It's all the side gigs that go along with that, whether it's the radiology, the imaging, or whether it might be the lab that you might have, or the clinical pathology stuff that you might have, or it might be the endoscopies or surgery centers you might have. That's kind of where all the money is to be had. That may be shifting. I mean, there's a whole bunch of changing going on in terms of reimbursement, so you might not see that. But in my experience of the last 20 years, the money really is in the access to the ancillaries. And when you work for a tax-exempt hospital system, I do a lot of work on both the hospital side and the clinic side and the independent physician side, so I kind of see it from everywhere. I can just tell you that large healthcare systems, because they're tax-exempt, the compensation has to be reasonable. And yes, to Dr. Flynn's point, they use the same MGMA data, but they're going to be at the 50th percentile, and stretching to 75th percentile would be a shock. And there's a lot of places in the IPA or in the independent physician group where they'll pay on the higher end of that. But again, it's a lifestyle choice. It's about how much money you're making, and I think the comment that you make 3 times what any kind of normal person would make is you're all paid really well. It's just a matter, I think, of finding the right fit for you. So anyway, that's some background. Let me go through, let me just talk generally about negotiations. So in my experience, if you go to a big healthcare system, the Allinas of the world, the Fairviews of the world, they don't tend to negotiate. They've got 500 physicians all under the same physician contract. Now, having said that, I still, and of course I'm going to say this, but I will tell you, I think it's still worth having your contract looked at. because you want to know, particularly if you're comparing contracts, what one might be one advantage of another, or you kind of want to know what the traps are, because there's nothing worse than getting surprised. And sometimes I work with physicians who end up getting surprised because they haven't looked at it up front. The smaller groups, it's easier to negotiate on a lot of these things, but they also are very wedded to kind of treating everybody equally, and sometimes it can be really hard to break in, and we'll talk about non-competes in a minute, but I'll say just for example, I'll often say, well gosh, this doesn't seem quite fair, and you might want these exceptions for the non-compete. I hear back, well everybody has that non-compete in our practice, and I always say, okay, fine, put your money where your mouth is. If you ever negotiate a better non-compete for anybody, mine gets improved as well. So there's kind of some sort of leveraging you can do, but you're always trying to sort of address kind of the culture around physician contracting. I do have some physician clients when I represent the clinic who they will, if they make a change for an incoming doc, make the same change for everybody. And that could be a lot of work if you have 10 or 15 doctors or 20 doctors on staff. So I do think it's worth sort of looking at these things, even though you may not be able to negotiate something, but you will go into it with your eyes open. Okay, so how do I move the...
You can use the mouse or the keyboard, Claire.
The mouse, okay, got it. Okay, so I'm going to take some of these, and some of these, because I only have this short window, in some cases I'm just going to do them topically, and in some cases I'm going to take the language. So this first one is, and I'm trying to give you the anatomy of a contract. So the first one, during the term of this agreement, employee agrees to devote her full time and best efforts to the practice and affair of employer and to provide physician services at the employer's offices. So that actually seems pretty straightforward, and it is. The reason I have it in here is because later there's a discussion typically around a non-compete. And a non-compete will tend to radiate from the employer's offices. So if you're working for Allina and they have 400 physician clinic offices all over the state, and you're only at one of them and you're only ever going to be at one of them, if the non-compete is broad enough to radiate around the offices, you're going to want to be thinking about those offices and whether you should be arguing that it's only those offices where you spend most of your time or over half your time or your primary facility. So it's really important to be aware of the employer's offices. Similarly, there's many contracts that have that are based on productivity, and we'll talk about comp a little bit more in a little bit later. When you look at physician compensation, you sometimes will be stuck out of clinic. So some physician group wants to open a new clinic. They put you out there because you're the new doc. Great. But you, at some point, after you're off your guarantee, you're the one that you're completely dependent on productivity. Well, it's important to know where they're planning on putting you. Are they going to have you drive between a whole bunch of clinics? Are they going to have you set up one place that's a new place where there's not a lot of physician revenue coming in because there's not a lot of patients that are yet being seen? So you have to sort of get some sense of the offices and kind of what that means. I put call coverage here because Dr. Flynn and I actually were talking about it offline, about how in terms of lifestyle choice, call coverage is such a big issue. And what are the responsibilities with respect to call? And you should be asking that question. Not every employment contract will have it specifically in there. Sometimes if you're highly specialized, they will designate, what your call is. So I represented somebody who was a bone orthopedic oncologist and also a tumor specialist. A trauma guy. He didn't want to do trauma call. He didn't mind doing the orthopedic call. So we had to negotiate around what his call split would be. Now he was very specialized and he didn't want to get sucked into the trauma trap. So he was really clear about, I'm only willing to do this much of this kind of call at this time. I will say generally they need some flexibility. So the best you can do generally when negotiating around call coverage is to say that it's going to be approximately equally shared among the physicians. I don't know whether this happens still, but it used to be that the retiring physicians, as they were getting older and they had kind of earned their keep, they're the ones that want to stop doing call, and the new physicians who've got all this energy are the ones that end up doing a lot of the call. Or sometimes there's an unfairness in terms of how that's allocated. So you really have to understand how that's allocated, if you're going to a small group, how that's going to be shared with other groups, and understand what that schedule looks like. You do have to be flexible. That's one of the tricks here is no matter how much we try to prescribe in the contract something, both for your benefit and the benefit of the practice, there needs to be some some willingness for you to kind of step up, you know, when you need to, when they need you to, and for them to give you some space, vice versa. So you try to set what the rules are, you try to put the rules of the road out there, but you need to sort of understand that there's some flexibility in that. Rules, regulations, and standards. This is very common. Employers shall have the right to determine, set, and approve the employer's policies. Employee agrees to comply with the, do you like this one, written and unwritten policies and customs of the employer as they may be amended, modified, or changed from time to time by the employer. Now, if we had time, I'd be doing this all Socratic method with you, and I'll have you raise your hand, tell me what you think is wrong, but I'm going to just, because I'm going to be short on time, I'm going to kind of fly through these. So unwritten policies, you don't usually see that very often, but every once in a while it kind of sneaks in there, and you know, unwritten should come out. But it is the case that usually your contract will say that there are policies that may be amended, modified, or changed from time to time by the employer. That is a blank check for the employer. Every time I'm on the employer side, I always put it in. Every time I'm on the employee side, I always argue it shouldn't be in there, and I know I'm going to lose. Because as an employee, they should have the right to change their policies. So the only control you have over that is twofold. One, get a copy of the policies when you start. Make sure you flip through them and take a look at them and understand what they might be, because they can give you a flavor of it. One example, and it was a rheumatologist probably 15 years ago, she had this is actually from her contract, and I said, well, when do you ask for the policies? So she looked at the policies, and there was a policy that said she had to provide a copy of her federal income tax return every year so they could verify whether she was moonlighting on the side or not. Now, that for her was just, she didn't want to work a place that they didn't believe her, didn't trust her. So for her, it was sort of a cultural definition of what it must have been like to work in that place. So you can't always tell, but sometimes when you look at those policies, you'll get a feel for the place in terms of what they're looking for. Sometimes there's policies about record keeping and productivity and about kind of your responsibilities, about patient care, about referrals. There's an awful lot sometimes about healthcare systems in particular trying to capture their referrals in terms of within their system. So there's just a lot of information you need to know, and they can change it at any time. Some employment agreements will say that they can change it, but they have to notify you when they change it. Some, every once in a blue moon, I've been able to get that they'll notify you, and if you don't like it, you can terminate, but that's pretty rare. You just kind of have to realize it, but you should for sure be seeing the policies. The language at the bottom is actually because I want to make you understand that often your failure to comply with the policies is ground for termination. That's usually a really classic grounds for termination, which is why it's so important to understand what they are and understand as they change. All right. Now screw that. Okay. Term and termination. So this is one, commence on September 1st, 2014. Continue for 3 years. Okay, so you think you've just signed a 3-year contract. And then it has, employer may terminate this agreement without cause on 90 days written notice. Well, it should be written prior written notice, but it says written a notice. Okay, you just signed a 90-day contract. You did not sign a 3-year contract. 99% of contracts, employment contracts, have without cause terminations. Whatever that without cause termination period is, defines the length of the contract. So you might ask the question, well, why put a term on a contract at all then? And it's really because they want to show their intent, but they want the flexibility to be able to say, yep, but if it's not working out, and they can let you go for any reason as long as it's not an illegal one. So they don't like the color of your shoes being blue, they can let you go, but they can't let you go because of your sexual orientation, your race, your gender, those sorts of things. So without cause termination, very common. It should be reciprocal. If they have the right to let you go, you shouldn't have to stay that whole length of that contract. You should have the right to go. Typically it's 30, 60, 90 days, sometimes 120 days, but primarily kind of in the 60, 90 range. Double-edged sword, the longer it is, great if you're the one that's being let go, but not so great if you're the one that wants to walk out the door. So it's really important to understand the without cause termination provision. Then there's a whole slew of provisions about for cause termination, which basically means you're being fired. For cause termination, now look at this magic language. This is lawyer language. When I'm on the employer side, I always put it in. When I'm on the employee side, I always take it out. May terminate this agreement for cause on written notice, including but not limited to. That basically means it's open. The world's open as to what those things could be. Here's just a list. It should be, because there's consequences of being let go for cause, it's really important to be really precise about what exactly constitutes cause. Now this first one is my favorite, and it goes to working with, being with people that you like. And I will tell you, anytime I see this contract or this provision or one like it, it tells me that there's been a problem with the practice. So, failure to establish a harmonious working relationship with the doctors or office staff of employer or its referral sources or related parties or hospitals. This is the classic one where you have a really talented doctor, one who's just really, really skilled in the art, terrible bedside manner, terrible reaction and interaction with the nurses and the various support staff and with the receptionists, and sort of just the office demeanor, and you can't get rid of them. So this is being an employer kind of on that side of it. So some of my clients say, well, do I really care? I'm pretty harmonious. And I always say, well, if, part of it is trying to understand where this language is coming from. And if you ask, they'll often say, yeah, we had this awful doctor and we couldn't get rid of him, and so we added this in after the fact that, they're long gone. But it does tell you something about the group, because actually they want a harmonious place that, and that might very well be a place that you want, unless you're one who might not be good at establishing those collegial relationships. You do see this, and actually I will tell you that just this week I was asked, I have a client that's got a doctor who really talented, but just a nightmare personality-wise, and they've asked me whether we can revise their contract to add this kind of language, so that going forward they have some ability to let go of the doctor. Breach of this agreement, that's a problem, because usually it's material breach, and usually there's a notice and a cure period. So it's normally material breach of this agreement, which breach cannot be cured, which means fixed in the legal context, within, pick your time frame, 5, 10, 15, 20 days of receiving notice of it. This is pretty common, engaging in any activity that might adversely affect employee's reputation in the community, determined in the sole discretion of the employer. So when I said, including but not limited to is lawyer wiggle room, the language in the sole discretion of employer basically says you could argue till you're blue in the face that that's not a legitimate basis, and they win. So that language in the sole discretion of the employer should always be struck out. The other problems with this, it'd be fun to sort of ask you all what you think, but the other problems with this is it might adversely, maybe, hypothetically, should be adversely, not might adversely. And it probably should be materially adversely affect. It should be a big deal. It shouldn't be just a little deal. I do have a hospital client that actually had a physician who was on his weekend and decided to take off all his clothes and expose himself. And they wanted to let him go. Now he was up in the northern boundary water area, and they were down in this area. So the question was, is that a reputation in the community? Now there happened to be a picture in the paper, which created a whole bunch of issues. But this kind of language can kind of, because there's so many consequences that come from being from being terminated for cause, not the least of which is sometimes the notice has to go to the Board of Medical Practice and to the state reporting, the federal reporting board, so you have to be really careful and trying to be very narrow. So usually we would try to tighten that up. Employees arrest for any crime. I hope you all know that you are innocent till proven guilty. Arrest should not be sufficient, it should be felony. And it shouldn't be any crime, it should be, otherwise you'd be in there for, well, felonies, I guess you're okay. All right, compensation. I want to leave you some time for questions. I know I'm flying, but I'm trying to tease you all about this. Compensation. So, employer shall pay employee the compensation and provide to employee the employment benefits to which the employee is entitled pursuant to the compensation policy, as is in place from time to time. Employer expressly reserves the right to modify the comp policy at any time. So, one of you guys asked, well, are you supposed to negotiate this up front? Yes. Do you always know? You should know. Is there a guarantee? Yes. Now, this came out of a big systems contract, and what I don't have here is a provided, however, in the first few years your compensation will be no less than X. So there's kind of a floor. But the reason I keep this in my presentation is because it flags for you that you don't have certainty with respect to what happens after those first couple of years. So you want to be thoughtful about what your exit strategies might be if it's not paying like you thought it would be. You also want to know who makes that decision. You want to understand whether it's, if you're in a multi-specialty practice, for example, is your specialty going to be representative on there? What is the internal process that the group uses to make those changes? Presumably, the compensation policy applies to the entire group of specialties or specialists, and so it's not just you that they're changing the comp for, it's everybody. But it is really common. You get protection those first couple years, and then all bets off after that. The reason I have this one is, this is actually kind of a complicated one. So in addition to a base salary, so they'll give you kind of a base salary in those first 2 years and even thereafter, employees shall receive a bonus equal to 30% of the actual annual cash receipts received by the corporation for the production in excess of $300,000. Okay, so that's collection based. That is based on how much is collected, not how much is billed and not what your RVUs are. If it's based on billings or based on RVUs, then you get kind of instant credit for providing the service at the time you do. If it's based on collections, there's a 90 to 120 day lag in those collections coming in. I think that's shortened up with some of the electronic billing, but there's still a delay. So you have to kind of figure out, well, what happens to that money that rolls in the door after I leave? If I'm leaving without cause because they've run out of stuff for me to do, how do I make sure that when I'm paid that money that for those 3 months that rolls in that I ended up generating? Sometimes practices will let you sort of capture that on the back end and sometimes not. When you roll into being a partner, sometimes that's captured in your deferred compensation arrangement, so there are ways to capture it. But the other thing you have to think about is in that first year, that $300,000, that's based on 9 months of revenue, because that last 3 months of revenue isn't going to come into the next year. So the question is, can you adjust that? And what happens under all the different grounds for termination in terms of who gets that money? Absent doing anything with it, the contract would provide that they get the money, not you. And that's one that people just wouldn't see if they were looking at the language, because it just looks like, oh, I get it above $300,000 annually. You don't sort of key into the fact that that's based on collections. I will say that more and more it's based on RVU, and this issue sort of has gone away, but every once in a while we see it based on collections. So malpractice insurance. This is one of my favorites, and actually this came out of an OBGYN contract about 20 years ago, my first one. Employers shall obtain and maintain in full force and effect during employee's employment under this agreement a policy or policies of liability insurance naming employee as insured. You think, great, I got malpractice insurance. Okay, so imagine you're the OBGYN that thought, great, she had malpractice insurance, signed it, had completely forgotten about it. 15 years later, she's getting let go. And she says, okay, I gotta go. And the practice says, yeah, or actually the practice is letting her go. And she says, okay, so how does my coverage work then? And they said, oh, well, we have a claims-made policy. And she says, okay, so what? And they said, well, that means that tail has to get purchased. She says, well, you're paying for that, right? Nope, you have to pay $45,000. So for those of you that don't know, and I could do a whole hour about this, I'll try and do it in 2 seconds. So insurance, malpractice insurance is divided into either claims-made or occurrence-based. Occurrence-based means you're covered no matter when the act occurred. So you could leave, it could be years later, and the claim comes in and you're long gone, but you were covered because the act occurred when you had coverage. That's the best kind to get. Very few places have it. The other is called claims made. You're covered as long as the claim is made when you're covered, which means if you're gone and you're no longer covered by it, you don't have coverage unless you buy tail. Claims made plus tail equals occurrence-based. Self-insurance is also more like occurrence-based. You don't have to worry about tail. So you look at this and you think you have insurance, but it's silent about whether or not it's occurrence-based or claims-made. You need to know which one it is. You need to ask. And then usually, if it's claims-made, you need to say, well, who's going to pay for tail and what are the circumstances? And there's sort of 5 different ways that it can be done. It can be the longer you're here, the more we'll pay, kind of as a retention piece. It can be we'll split it. It can be you pay it. It can be we'll pay it. Or maybe we'll pay it under certain circumstances and you pay it under certain circumstances. So that's highly negotiable, negotiated all the time, and different groups have different approaches to it, and you gotta ask the question. You have to know what it is. There was a question earlier about can you get other coverage to kind of cover you under your homeowner's policy or some E&O policy, and that's best actually answered by an insurance agent. But what I'll tell you is that you have great coverage under these. It used to be 1 million, 3 million, now it's mostly 2 million, 4 million, sometimes it's 3 million, 5, but it's, there's some degree of coverage. I've got a client right now that actually the amount of the malpractice claim, if it comes in, is going to be higher than the limits on the policy. That's when you have to worry, and I think that's the question that was being asked, is what if I don't have sufficient coverage under my policy to cover, God forbid something happens to a child, for example, so they have a long life ahead of them and they don't die, they're severely injured and disabled over their lifetime. What do you do to protect yourself? And I do think it's a good idea to talk to an insurance agent about that. I have seen some sort of get some kind of group coverage for those kinds of things on top of that malpractice insurance. But it's pretty rare for people to think that far ahead. They pretty much are just, hopeful that whatever, if anything happens, it's well under their insurance limit. What I'll say in a minute's time is covenant not to compete, non-solicitation. Most contracts have them. If they don't have a covenant not to compete, it's because you have a doctor who had a really bad experience in a group and philosophically just doesn't like the idea. But most groups will have them. They are reasonable as defined by state law. Some states find them unreasonably inherently. So I don't believe you have them in North Dakota. I think California is rare, if at all. Florida, I don't think you got them. So there are a whole bunch of different states around the country, and we've got a book that's got all the different states and what the rules are in them. In Minnesota, they are reasonable. If they are in time reasonable, which is anything under between 1 and 3 years after you leave a practice. 3 is pushing it, but 1 and 2 you typically see. Geographic radius, it's basically the radius from which the practice draws its patients, and how far are people coming to see that specialist. In a remote geography, you'll see a further radius. I'd say in the Twin Cities, it's typically 5 to 15 miles. And then you have this question about, does it radiate around each clinic or the clinic where you provide services? And non-solicitation provisions tend to go hand in hand. We tend to put we used to say, provided however you could put an ad in a newspaper of general circulation that you were opening a clinic. Now we say you can have a website or some sort of an internet page that says you're announcing, as long as you're not generally soliciting. I will end with, and then we have a few minutes for questions and I can stay after. Kind of leave and fringe benefits. Somebody mentioned CME. That's negotiable. Typically we see $3,000 to $5,000. Health insurance, whether it's going to cover your dependents. I will tell you that a lot of these benefits, it's whatever they've got, you're going to get, as it relates to health insurance or disability insurance or those sorts of things. CME and vacation sometimes can be negotiable, but they'll tend to have a rule of thumb about how that works. But I have seen some physicians be able to negotiate an extra week because they are terribly wanted. 2 other quick comments. Terribly wanted, what a terrible phrase. 2 other questions, or points. One is recruitment. Sometimes, depending on if you're particularly going to a rural area or you are highly specialized, there are recruitment packages, and by that I mean they'll pay you $15,000 or $25,000 or $10,000. If you stay and then it's forgiven over time, it's sort of structured like a loan. So there are a lot of ways that can be structured, but you want to be very careful about how you structure that. And buy-in. There was a comment earlier about the fact that often when you go into private practice, you have the opportunity to buy into a practice. And that's true, and it tends to be kind of 1 to 3 years, 1 to 4 years, depending. Sometimes it's just a nominal amount, like $2,000, and sometimes it's $100,000. Good to get the information up front. In my experience, it usually says, if we like you and you like us and we mutually agree, we'll give you the opportunity to buy in on the same terms we offer it to everybody else. And it's rare that up front you lock into what that looks like. All right. That is questions. Yes.
Since you're on the kind of compensation, what are the common pitfalls you see with like sign-on bonuses and then loan reimbursements?
Yeah, so the biggest one is that usually they have to be paid back if you don't stay a long enough period of time in the community. And that's okay, but not if they have a without cause termination provision. So if they can let you go on 30, 60, 90 days notice, you kind of pick up, you move your whole family there, you get there, and then a year into it, they're like, we don't have enough work for you, you gotta go. And then you have to pay it back on top of it. That's adding insult to injury. So I think that's the biggest concern, is making sure that if there's a without cause provision on the termination provisions, that your loan repayment is not triggered. But otherwise, it's a very common tool.
Can you talk more about what the non-compete covenant is?
Yeah, so, and usually I have language up there, but in general, it basically says that you can't provide services either as independent contractor, as an employee, as a consultant, as an owner, in any form you could possibly imagine, for another clinic, sometimes hospital, if it's a hospital-based practice, you gotta be careful about how that's written, within a certain radius for a certain period of time. So you literally can't provide services right there. And there is a thing under Minnesota law that basically says, you know, you've got a skill that's important to the community, you ought to be able to provide your services somewhere. But there's always this idea that the radius, if it's small enough, you can go across the river, or you can go into some different part of Minnesota and provide that service. And some people wait it out. Some people will like, well, I'll go here for a couple of years and then I'll come back. Does that answer your question?
Yeah. So say you are switching from one group to another, you have to wait a certain period of time.
If it's within that radius, yeah. That's why that radius is so important. And that's why it's really important to understand the exceptions. I wouldn't have it apply if they're letting you go without cause. If they're not busy enough for you, you shouldn't have a non-compete that follows you. That doesn't seem right. Not all groups will agree to that exception, but we try. Or if you have to leave because they're breaching, that also should be reason that that's not following you. But that's exactly right. One other just quick aside, and I'll just say it. I think Teresa noted that, you know, the $400, $500, $600 an hour lawyer. What I'll just say generally is it's about $1,000 to $1,500 investment on your part to have a contract looked at by me, for what that's worth. I think that's kind of ballparky going rate.
That was my question.
Oh, okay. Yep.
So we've seen a lot of examples of sort of dubious contracts here. Is that the norm, just kind of the nature of the game, or is that something that should raise some red flags when we're going through a contract and sort of seeing these things? I mean, does that tell us that this is a potentially bad employer, or is this just the way the game is played?
Really good question. What I'll say is, I mean, you're getting an unfortunate slice, because I put together a contract with all the worst of everything I've ever seen. What I'll generally say is, like that, you know, policies, employers' policies, which can be amended from time to time, you'll see that in every single contract. You'll see this issue about tail insurance in every single contract. You're going to see this issue around malpractice in every single contract. Some will be more physician-friendly, some less physician-friendly. I don't think it's a red flag. I mean, every once in a while I'll say, oh, God, I've never seen that. I'll give you an example just real quick. Indemnification. So indemnification means that if the practice gets sued because of something you did, once in a blue moon they'll say, you have to cover the clinic's expenses. Their lawyers, their judgments, and all of that. Now, I think that's completely upside down. I would never sign a contract if I personally, little old me, had to pay for that. So those kinds of things, you'll see every once in a while something that's a real stretch that nobody else, but all of these issues, I gave you the extreme, but in some form they show up in all of these, and I'm just trying to get your attention, that you gotta pay attention to them, and some are negotiable, some are ones that you're willing to live with, some are, you just have to have your eyes open to understand what's out there. But I wouldn't, no contract has all of this. Yeah, in the way back.
If you sign a non-compete and you're in a specific specialty but decide to moonlight in the ER, is that illegal?
Really good question. It depends on how it's written. Sometimes it just says practice of medicine, right? So if you're smart about it, you might say, you know, practice of family practice or internal medicine and not including urgent care or not including emergency room, but it's all about how it's written. There's a lot of locum tenens. I have a lot of clients that'll go do ER sort of or urgent care, and they'll fly around the country and they'll go outside the radius so that they can do something. And we didn't even talk about moonlighting. There's moonlighting provisions in here typically about circumstances under which you can do that. One other just little thing, so I've been doing this for years with physicians. Physicians are all really busy, you all have patients. So I do it on evenings and weekends because there's just no other time to talk to a doctor, so just an FYI.
So just in the future, let's say our name ends up on a contract with an unreasonable provision that we somehow signed. Is there any recourse if that provision isn't, like, doesn't logically make sense from a common sense standpoint?
Oh, I love that question. No, welcome to the world. No, I mean that's the thing is, now there will be some provisions that are unenforceable. Like if the non-compete is, it's a 500-mile radius and it's a 10-year, period of time. But then you can find yourself in court fighting over that. So there are some things that are not enforceable, but I think you're asking a different question, and that's based about the only one that's not enforceable is the non-compete. Everything else just might be, you were not the wisest to sign it, doesn't make good business sense. language is ambiguous and confusing, but you sort of have to live by the contract you sign, which is why I always say look at termination rights, your exit rights, you know, how you can get out of it, whether you can. I don't mean to scare all you. I mean, there are a lot of really wonderful employers out there, not the least of which, and I will put in a pitch. I did represent a physician who went to Minnesota Oncology, and they have a great contract. They have a really well-balanced contract.
But to your point, it's well worth the investment before you sign the contract that's going to govern your employment for the foreseeable future to have a lawyer with your interested party look at it. Well worth it.
Other questions? Yeah.
Is it difficult to negotiate things like certain time dedicated to research or going abroad into a contract?
Great question. So about special negotiations for time or special time for things, whether it be research or other things. By the way, I should, so it depends. So my guy who was a trauma tumor oncologist guy, he wanted to do research. He wanted to do it 0.2 FTEs, and he was able to negotiate that with the healthcare system he was going to. So it really kind of depends on what you bring to the table. I will also say that my style on these is I sort of give you the language to negotiate. It's more expensive for me to have to interact, and then they got to pull in their lawyers. So I always try to give you kind of the best arguments for you to make at that, and I typically try to empower the doc to do their own negotiation. But it just depends on what under what circumstances you want to do this and why, and whether it's fair.
Is the contract review state-specific? So I'm not planning to practice in Minnesota.
So the only state-specific is actually the non-compete, but we practice in all the states with respect to the non-compete. So, but that's the only thing really that's, some states actually have a limit on malpractice liability, so sometimes the insurance provision might look a little bit differently, but no, actually it's very, very standard across the country and standard across most specialties other than how much vacation you get. I wish I were a cardiologist or radiologist.
Well, we'll take one last question publicly, and then I think Claire has offered to spend some
Sure.
time if you have other questions. Yep.
To follow up that question, so then is it better to get a lawyer in your immediate area? Let's say I'm looking at a job in California. You know, do I want to find a lawyer to go over my contract who's familiar with the local practice in California and the standards out there, or to find somebody here that I can meet with face to face and have the discussions with?
I think it's one half dozen of the other. I mean, of course, I'm going to say, meet with somebody here because I'm here. But I will say that I think if you can find somebody that has experience, contact the California, Medical Association to find out the MMA. It's very, equivalent over there in California to find out kind of who they would recommend. That it'll be more expensive in California. You might be able to do that. I think all of us tend to do this work across the country because it's a very niche-y kind of thing. But it might be nice to have somebody kind of locally that can help you sometimes.